Hi everyone, welcome back. This is the first invigorating talk. I'm very glad to move on to our second session, and our speaker is Dr. Daniel Buchman. Dr. Daniel Buchman is a bioethicist and scientist in education research at the Center for Addiction and Mental Health, Toronto. He's also an assistant professor in the Dalalana School of Public Health at the University of Toronto, a member of the University of Toronto's Joint Center for Bioethics, and an affiliate scientist in the Krembil Research Institute at the University Health Network. Dr. Buchman's general research area explores ethical issues at the intersection of clinical practice and public health, and in recent years has been studying the influence of novel predictive technologies such as machine learning on mental health care. And I just find that kind of intersection of bioethics, machine learning, and mental health to be really fascinating and underexplored. So I'm very excited that he agreed to speak today. He'll be speaking about potential stigmatizing consequences of predictive technologies in mental health care, the need for epistemic humility. Please join me in welcoming now.
Thank you, Dr. Tall, for the introduction and the sort of very kind invitation to be with you all today. It's great to be here. It's also very special for me to be back at my alma mater at McGill. Sort of did a little bit of a nostalgia tour yesterday, walking around, and very, very similar to what it was many, many years ago when I was here. As Dr. Tom mentioned, I'm a bioethicist and a scientist, and so and also a consumer of mental health services, and those are some of the lenses that I'm going to bring today to this discussion. In my role as a bioethicist, I provide healthcare ethics consultation to I think the largest academic psychiatric hospital in Canada. I also have my small but mighty lab, which I'll say a few points about a little bit later, where I also explore ethical issues as they relate to mental health, substance use, and chronic pain, where those topics individually, but also where they intersect as well. And so I think, it goes without saying, and this group knows very well, that there is a considerable excitement about the promises of improving mental health care delivery with artificial intelligence, machine learning, as well as with brain imaging. Proponents suggest that leveraging big data, so we're talking about big data, we're talking about genomics, demographic, and various environmental information, can help improve access, diagnostic accuracy, can help guide prognostication, discover new treatments, and provide more efficient and ideally higher quality patient-centered care. I'm focusing on predictive technologies and the potential ethical consequence in this context, as the consequences of doing so in a mental health context, because we all know, are not trivial. Some predictions may contribute to unnecessary institutionalization, undermine patients' credibility about their own experiences, and perhaps in some extreme cases, contribute to decisions to remove a patient's right to make their own treatment decisions. And I think for me, this topic really reveals sort of the entanglement of epistemology and ethics, and of which I'm going to address today as it pertains to questions of stigma. So just some acknowledgements.
If you use the mouse to click on anywhere on the slide, you should be able to then promote it. Yeah, now you're able to.
Just to acknowledge that a lot of the content I'm going to talk about today was funded by a fellowship in compassion and artificial intelligence that I received from AMS Healthcare, as well as I've had funding, some internal seed funding from the Dalalana School of Public Health and the University of Toronto to look at fairness and bias and risk in the psychiatric emergency department, and acknowledge my colleagues and collaborators at Center for Addiction and Mental Health and the Professional Practice Office, where I'm a bioethicist, also in ChemH Education, where I have my lab, the Everyday Ethics Lab. And so many of the ideas that I am presenting today have been, generated with, this wonderful group and very extremely thoughtful group of RAs and students and other collaborators. We sort of consider ourselves sort of a motley crew, some kind of collective where anyone can jump in and join in and out, and we really sort of benefit from the exchange of ideas. I'm going to also be drawing upon heavily on two papers that I've published on this topic. The titles you can see on the screen here. They go into far more nuanced detail than what I'm going to be able to sort of cover here today. But I wanted to sort of recognize them and also my colleagues who we work together on this. So the outline that I have today, I'm going to talk a bit about stigma, talk about a little bit about predictive technologies in mental health. I'm going to center a lot of the claims and arguments that I make in the discussion on psychiatry and the history of psychiatry and the quest for objectivity and certainty, which I think sort of scaffolds a lot of the concerns that I'm going to raise today. I'm going to talk about some of these potential unintended consequences for stigma, and then move toward what I'm going to recommend is that we ought to move towards an epistemic humility. So here's a brief case description. So a patient is undergoing surgery for which post-operative opioid therapy is indicated. A machine learning system built into the jurisdiction's prescription drug monitoring program, or PDMP, is designed to assess risk of opioid use disorder and predicts that she is at high risk. The physician is legally required to consult the machine learning system and states they will not provide her with opioid treatment. The patient objects, noting that she has chronic pain secondary to endometriosis, which is greatly ameliorated by opioid medication when needed. She has managed her condition without issue for over a decade, and nothing else helps her pain. The physician knows the algorithm is widely used in practice, and so the physician assumes that the patient is quote-unquote drug-seeking and declines to provide an opioid prescription. This is not a fictitious case, something that we did draw upon in our paper, and it's based on an actual case that the journalist Maya Salovitz has documented in a wonderful piece in Wired in 2021. It is also not fictitious because machine learning algorithms, although perhaps not ready for prime time in the area of mental health and substance use, are already being integrated into many clinical workflows. And in several US states, there is a predictive algorithm called NarxCare, which is integrated into these prescription drug monitoring programs. I'm not going to sort of give you the outcome or the punchline what happened in this situation. I encourage you to read Maya's piece in Wired, but I think it goes to it highlights. I want you sort of to sit with this because I think it underscores many of the points that I'm going to talk about here today. I think it goes without saying, and this group knows very well that mental health, substance use issues are highly stigmatized. For instance, people with mental illnesses are often considered dangerous and blameworthy. Stigma can be a barrier to recovery, as well as accessing healthcare for people, And also, because of these barriers, stigma can actually lead to worse health outcomes. Now, despite various efforts to reduce stigma in mental health, stigma related to mental illness readily persists and is entrenched within many lay publics, as well as healthcare professionals. And within healthcare professionals, particularly concerning, because so first of all, mental health care professionals harbor a lot of stigma towards the people that they work with. And this is particularly concerning because it can lead to less compassionate, empathic, as well as high quality care. So what's stigma? Stigma is a social process, and it's heavily reliant on contingent access to various social and economic and political power structures. At least that's how I view stigma. I view stigma as being very structural. So in the literature, you can see that it's enacted through this process that involves labeling, stereotyping, power, status loss, discrimination, and I think importantly, and then this is also important for me as a bioethicist, normative judgments of deviance. So someone who has this label is labeled as deviant or abnormal. I also consider stigma as a social determinant of health, as an independent social determinant of health. So if you're actually going to be stigmatized in one domain about your life, for example, let's say because of your mental health concerns, you're also most likely to be stigmatized in other areas of your life. For example, if you experience homelessness, if you may be stigmatized due to your gender. And these intersecting densely woven patterns of systematic disadvantage and stigma are actually really bad for your health. And these ideas are rooted in notions of prejudice, discrimination, and marginalization. So I'm going to talk about the relationship between stigma as well as these predictive technologies in mental health, and particularly a couple of predictive technologies that are being heavily researched in this area. So brain imaging as well as AI and machine learning. So in this presentation, I'm going to use the term AI very broadly to encompass a very broad range of algorithmic systems, including machine learning, deep learning, and where these systems may be both supervised and unsupervised. And I think one hope or assumption behind many of the uses of these technologies is not only would they improve patient care and high quality care and access to care, as I've mentioned earlier, but actually in some ways they will have the effect of reducing stigma or even eliminating it and helping to increase access to treatment, because mental illness, by using some of these technologies, actually will be seen as a disease like any other and afforded a lot of medical legitimacy. So I think neuroimaging and AI and machine learning have actually made very important strides in improving the potential prediction, diagnosis, and treatment of mental illness. But I think I want to emphasize that what I'm talking about here is the research is still in its very, very early stages. And so researchers are using various types of technologies. I mentioned leveraging big data before. So we're talking about electronic health records, brain imaging, social media platforms, we heard a bit earlier, sensor-based monitoring system, and sort of how this is all sort of taken all together and producing what's called a digital phenotype. And these research in digital phenotyping is the anticipated benefits of this is that it could help predict risk of mental health issues. It could help predict relapse, as well as potential for the earlier intervention and treatment. But as I mentioned, so these are very much within the early phases of research. But a lot of these technologies that we're seeing, these rapid developments in, which stand to have huge benefit for patients and populations. I'm going to sort of situate it today in this idea of sort of the history of psychiatry and the politics of psychiatry and mental health and its quest for objectivity and certainty. And so, unlike other areas of medicine, there really aren't any so-called objective tools, for instance, like a blood test, to confirm whether someone's experiencing a mental illness. And so there's been a lot that's been written over the years, which I'm not going to get into here, about the so-called biomedical aspirations of psychiatry and the so-called decades-long crises of uncertainty regarding areas like diagnosis, etiology, and treatment. And indeed, clinicians do, in mental health, rely very heavily on subjective factors such as patient testimony to make determinations such as diagnoses. And sometimes, unfortunately, the patient's account does not necessarily align with the assessment by the clinician of their symptoms or their behaviors. And this uncertainty is sort of one reason why psychiatry has historically been considered less scientifically rigorous by its biomedical counterparts. And I think that, and so over the last century, there's been movements within psychiatry to promote various data-driven statistical and algorithmic approaches to clinical judgments that attempt to eliminate or carefully control various confounders, values and biases. For example, there's been considerable effort and resources put towards identifying neuroimaging-based biomarkers and reconceptualizing psychiatric diagnoses versus transdiagnostic frameworks, such as the research domain criteria, to improve explanations of psychopathology and to better target and tailor treatments. However, I think despite the advances that have been made in these areas, identifying reliable and objective clinical biomarkers has been quite challenging. So the enthusiasm for predictive technologies in mental health care speaks, I think, to the desire amongst clinicians and families and patients to promote the best interests of their patient, contribute to their well-being. After all, clinicians ought to apply the highest quality scientific evidence to support clinical decision-making. And given supposedly reliable scientific processes informing the algorithm, it should actually warrant a very high level confidence in decision-making. So I actually think because of all of this sort of taken together, clinicians may feel that some of the advances in these predictive technologies, they may feel a certain pressure, or perhaps even I might go as far as to say an epistemic obligation to view the advances of AI as corrective in the uncertainty work that has been described in literature as characterizing everyday psychiatric practice. So here's a quote from the World Psychiatric Association, the Lancet Psychiatry Commission, which I think highlights some of this quite well. So it says, the potential digital phenotyping might offer an unprecedented opportunity for psychiatry. A vast amount of new data is now available from self-report, behavioral, physiological, neurological, molecular, and genetic information. These data offer an opportunity to evolve the nosology of mental illness away from phenomenologically derived descriptions toward more personalized and reliable definitions. These digital devices allow the capture of more objective behavioral data. And so I'm going to argue actually that there are going to be some potential unintended consequences of these developments for stigma. Folks maybe sort of have seen images like this before. Joe Dumit's work back in the early 2000s, depression and neuroscientific facts, is it me or my brain? Really groundbreaking stuff. How different sort of normal versus abnormal are sort of juxtaposed in these images. But it really also comes down to within this, with the idea of neurobiological or biological reductionism and essentialism. And I'll sort of get to sort of what that means in a sec. So neuroimaging data has been, I think, a particularly persuasive tool in reinforcing a kind of neuroessentialism. So neuroessentialism, or like think of folks familiar with the term essentialism generally, is the idea that the essence of identity can be reduced to the brain. So in other words, you are your brain. And I think the way imaging data has been presented and perhaps even used has been a very sort of very successful in creating pathological identities, constructing kinds of brains, as you can sort of see in this picture here, that stand in opposition to so-called normals. So appealing to neuroscience actually facilitates justifying the claims of pathology and naturalizes the constructed differences, in this case, for example, between I'm not going to use the sort of the stigmatizing terms here, but the person who uses drugs and normal. And so you can see how in these cases, the brains or even the addiction or the people, the populations themselves are positioned as sort of neurobiological others. And this encourages a categorical us-them type of distinction, and which is very central to the stigma process. So what is perhaps, I think, more troubling for me, and as I mentioned earlier, the advances in many of these technologies are intended to be good, to help people, to help populations. We're sort of slowly scratching the surface of mental health. There, in many ways, you see in the literature, people want these technologies to be value neutral. Any of those in STS know that there's no such thing sort of value neutral technologies. I'm not going to sort of get into that now, but and actually help reduce stigma. But I actually think these kinds of representations sort of continue to reflect and reproduce the pathological figure of the person who uses drugs. And this is not also just entirely just like an academic exercise. There's been some really interesting work that has happened over the last number of years that has tracked public views of mental illness and their attitudes about sort of neurobiological explanations of mental illness. So here's just a couple papers that I'll highlight here, one from 2010, and then they did an update in 2022. And just to highlight a couple points from these papers. So in what they did is they used the General Social Survey in the United States with 3 sort of different diagnostic conditions around, I think it was depression, alcohol use disorder, and schizophrenia, and asked participants to rate sort of their attitudes towards how biologically causal, I guess it is, do you see these conditions. And in 1996, which was taking data from the first paper, 54% of the sample attributed depression to neurobiological causes. When the authors updated the survey for the 2010 paper in 2006, 67% attributed depression to neurobiological causes. So did this have any effect on their attitudes towards stigma? Well, interestingly, it did not. What they actually found was that with increasing neurobiological attributions of mental illness, you had increased support for treatment, but stigma did not change. In the 2022 article, they actually found even less desire for stigma or a proxy measure called social distance. And, but again, they found the greatest changes in a reduced aspect of stigma with increasing sort of neurobiological explanations among different generational cohorts. So apparently, if you were born pre-World War II, you were had a less desire for stigma and social distance, as well as if you were a millennial. So I don't exactly know why, but I think that sort of was a very interesting finding. And so there's been some really fascinating research of the last number of years that has looked at neuro or biological, like genetic or neurobiological explanations of mental illness and its relationship to stigma. And so sort of in synthesizing this literature, I can sort of highlight three main points. One is that with these explanations, you do see overall an increased desire for social distance, so social distance is the degree of familiarity or comfort that you have with someone else who has, for example, a mental health condition or another type of condition. So there was increased desire with social distance, but also there was increased reports of perceived dangerousness, as well as what's called prognostic hopelessness. And I think this is really important. If you remember sort of why is mental illness highly stigmatized anyways, people are very fearful of people who live with mental health concerns. They perceive them as being very dangerous when they're actually more likely to be victims than actual perpetrators. And the idea is that somehow there's prognostic hopelessness in that they may not get better. They may not recover sort of in a very clinical sense. And this is consistent with other studies that have found that when with biological or neurobiological attitudes towards mental health, mental illness is actually considered to be more innate, so something that is within the person and unchanging, perhaps related to some of the aspects around prognostic hopelessness. However, some qualitative research that has been done, including some work that I've been involved with over the last number of years, has actually found people who are living with various mental health diagnoses really want an image of their brain, or they really want that objective indicator of their condition because they believe that it will help mitigate stigma, because their experience only in that case would be considered objective and real. And one study I did with people who were diagnosed with mood disorder and their perceptions on neuroimaging, they said, maybe actually my doctor or my family would believe me. And so there is this desire for that, with the idea that somehow if I can only legitimize this medically, it could reduce stigma. So since stigma can have a very pernicious effect on the health of already disadvantaged populations, and we know that this is coming from neurobiological causes, what we want to do in our group is understand, well, there's all these advances in AI and machine learning, may they similarly influence stigma and perceptions on the similarly influence stigma? And particularly, may they actually similarly influence stigma among healthcare professionals who we know harbor a lot of stigmatizing attitudes. So what we did is we did a contrastive vignette study where our goal was to evaluate whether the description of a machine learning app, brain imaging technology, or a psychosocial assessment to predict the onset of schizophrenia or alcohol use disorder influences healthcare professional judgments of stigma, empathy, and compassion. So what we had is 310 healthcare professionals from Canada and the US participate. They were randomized to one of these three vignettes, and the vignette described someone named Jane, who was worried about developing either schizophrenia or alcohol use disorder, depending on the vignette. And also depending on the vignette, their healthcare professional ordered one of these predictive technologies. We used psychosocial assessment as a control condition, as sort of the kind of what is current in mental health practice. So what did we find amongst health professionals? I'm gonna draw your attention to the highlighted parts here on the screen. So what we found was that exposure to the machine learning vignette decreased participants' level of anger towards Jane. The person in the vignette was named Jane, but had actually the detrimental effect of increasing fear relative to the psychosocial vignette. Additionally, we found that exposure to the brain imaging vignette was associated with higher reported feelings of pity relative to both machine learning and the psychosocial vignette, respectively. Now, why is pity interesting? So pity is a dimension of stigma scales. And what we know from the literature is that people tend to have high reported feelings of pity towards someone if they feel that they're living with a chronic sort of condition that is unchanging. And we see this actually a lot from the disability study literature as well. So that's not necessarily a positive thing. And our results also suggest that exposure to the psychosocial vignette increased healthcare professionals' perception that people are somewhat personally responsible for developing their condition. So when compared to both brain imaging and the machine learning vignettes, healthcare professionals reading the psychosocial language attributed greater personal responsibility to Jane. This could be in part because such assessments draw heavily upon patient self-report and speculation of the relative weights of family history, circumstances, and environmental interactions. And this is quite interesting. So somehow, the exposure to the so-called more objective or perceived objective tools like machine learning, the app, and brain imaging, people were considered less personally responsible for developing their condition. We also asked questions about the perception around the accuracy and reliability of tools to predict future illness, and this varied within the vignette. So while I think, as we know, there are no established brain imaging and machine learning applications in mental health care, concerning the likelihood of illness, brain imaging was rated as more convincing than psychosocial assessment in predicting that Jane would become ill, but the machine learning actually didn't differ. Brain imaging was generally thought to be most accurate and reliable, followed by machine learning and then psychosocial assessment. And we'll qualify that we had very sort of small to medium effects here, but we did find sort of statistically significant differences nonetheless, suggesting sort of an effect of the experimental manipulation. As Dr. Henderson mentioned quite aptly today, a lot of this comes down to power, as well as power and epistemic hierarchies. And I think that we can't deny that power and epistemic hierarchy exist within healthcare, especially in the practice of clinical care, despite efforts towards sort of patient-centeredness and amplifying or listening to patient or clinic and service user perspectives. So if AI predictions or machine learning or brain imaging predictions are considered to produce knowledge superior to that of clinical knowledge or clinical wisdom, or expert clinicians, this may mean that the prediction could rank higher on the epistemic hierarchy than other forms of knowledge, such as this professional clinical judgment or patient experiential knowledge. Think back to that case that I included right at the outset around the predictive algorithm with the PDM, the Prescription Drug Monitoring Program. And also, we do have in healthcare various implicit rankings of technologies, and we actually confer more social authority and credibility on people who use different types of technologies. So you actually may see a situation where those who use or adopt machine learning or AI into their health systems and workflows may actually have more epistemic privilege than those who do not. I'm sort of thinking of some studies that I've seen on patient perceptions of robotic surgeries in different hospitals. And the perception that was that the hospitals who adopted these robotic surgeries for various conditions were considered better or good than the hospitals that do not. So we're talking about equity, geographic equity, who has access to these kinds of systems. I think that those are important questions that are raised here. And this, taken together, raises issues of epistemic injustice. And I think despite the goodwill of clinicians, the potential expanded apparatus of AI in mental health care may unintentionally create this kind of harm. And so, which may intensify the stigma toward people who are living with mental health problems. So epistemic injustice is a type of harm that is done to an individual or group regarding their ability to contribute to the benefit from knowledge. And I'm going to just speak specifically about testimonial injustice, which is a type of epistemic injustice. I'm just going to go through it very quickly. And I think people in general who are living with mental health problems are vulnerable to testimonial injustice. So for example, people who live with mental health problems are sort of considered to be cognitively unreliable or emotionally unstable. And this may often encourage others, including clinicians, to consider their testimonies as irrelevant, confused, or perhaps time-consuming. Just in the interest of time, I'm not going to go through these here, but I think these are two types of testimonial injustice that have been described in the literature, and I think actually both apply. So why does this matter for stigma? Well, I think around the perceived objectivity and accuracy of these kinds of predictive technologies, it risks that it may entrench the notion that already exists that people with mental health problems are not credible informants about their experiences. It may too reinforce the idea that mental illnesses are these unalterable identity-determined pathologies that are treatable but not necessarily recoverable. And I think as we've seen from some of the work that I've done that I represented here today, but also what we know from the literature, it actually may be what's called a mixed bag model of stigma. So it may reduce some aspects of stigma, such as personal responsibility, while simultaneously increasing other harmful forms, such as fear and perceived dangerousness. So this is why I think we need to consider how to balance the anticipated benefits of predictive technologies such as AI and brain imaging with the need to promote epistemic humility in clinical judgments. So what is epistemic humility? Epistemic humility is both a disposition as well as a commitment. So perhaps a virtue that clinicians ought to cultivate. I think epistemic humility, and as I've argued elsewhere, is an acknowledgement that predictive technologies in healthcare, inclusive of mental health and psychiatry, are accompanied by limitations of applying scientific knowledge to clinical decision-making, and also that clinical decisions are tentative and subject to ongoing revision based on additional data as well as other contextual considerations. So being epistemically humble on this view, it requires carefully balancing scientific evidence, clinical judgments, and I would argue also patient and service user experiential knowledge. But epistemic humility also is entirely relational. Given clinicians do not have the full picture of the patient's story, do not have the full picture of the patient's experience. And while it's important to invite that in part of discussion, I think I like this quote from Dr. Anita Ho, which talks about how the relational collaborative dimensions of it, that says, both the healthcare professional and the patient are counting on each other in investigating a full picture of the patient's experiences and determining the most appropriate management strategies. And so thinking back to that case example I had around where the clinician actually had a legal and professional obligation to follow the algorithmic risk score. This is not a situation that is very conducive to epistemic humility or actually inviting or prioritizing patient knowledge about their own experience and their own management of pain. And so I think why it's also a virtue that individuals need to cultivate, it's also, I would argue, a characteristic of claims. So the belief, I think, in the quality of the evidence is important, namely that of the scientific processes that produce the evidence leading to the algorithmic output. And this results, I think, in a kind of epistemic trust in the algorithmic development. And I think, as we all know very well in this room and online, there are many, many concerns with the quality of the data used to inform AI and machine learning systems in healthcare, including in mental health. And this includes the data sets that are used to train the AI, which themselves may be biased based on quality of diagnostic labels that you might have had in an electronic health record, or diagnostic labels used to train the system. We do know there are a lot of stigmatizing descriptions in electronic health records of patients. A lot of these algorithms are trained on electronic health records. Racism, et cetera, as well as we might see in many of these data sets, more severe presentations of people from underrepresented groups because of all of the barriers, the upstream barriers that people have in access to healthcare. So in summary, I would say that, the notion that predictive technologies might catalyze a more reliable taxonomy of mental health issues, as well as provide better predictions for people who may develop mental health issues, is understandably attractive. I think providing a technological prediction of something as etiologically and socially complex as a mental health issue may provide a sense of objectivity and value neutrality. As well, it may provide a lot of comfort to clinicians, who are really, and I firmly do believe this, trying to do the best for their patients and want to draw upon the best quality evidence in making these decisions. So the anticipated clinical applications of these technologies may reinforce essentialist views about mental health and may actually, as I've described, may lessen certain aspects of stigma while unintentionally increasing others. So, personal responsibility as well as fear, so this mixed bag model. And I think, sort of it goes without saying that eventually when we do get to the opportunity to have clinically validated tools in this space, they could be used as one resource alongside many others, including clinical expertise and finding ways to amplify patient experiential knowledge as well. So I will end there. Just the references I drew upon today, and just thank you all so much.
Daniel, for this wonderful talk. Ian?
Thanks for a great talk. Just two questions about whether you've done other stuff. So have you done experiments where you look at changes in fear, pity, and so on for physical illness? So to see whether there's something unique about mental health and stigma. That's one question. The other is it's very, very important to know, say, that brain imaging versus algorithmic stuff has these or those effects. Be curious whether you've looked at what it is about our beliefs about these technologies that's driving it. So have you done some experiments where you invent a technology and then you describe it in certain ways to see whether you can push people one way or another? I would bet, for example, that machine learning methods where we have no clue how they work, that those would be more impressive to people than ones where we do know how they work. Just question information.
Yeah, no, and thank you so much for the questions. So there is some literature that has looked at sort of, these are stigma scales that are done by Patrick Corrigan and others who've been looking into this for many, many years. So there is some in the literature. I am actually currently engaged in a sort of a similar type of project, but in the context of chronic pain. So and this is related to sort of various sort of cultural or neurocentric understandings of chronic pain. So just as mental illness and addiction is increasingly understood as a brain disease, what we're seeing also in the literature is that chronic pain is also being increasingly understood as a disease for many of the same reasons, right? To legitimize sort of like a subjective or visible condition, this highly stigmatized contentious condition. So we have, it's a multi-method study. I can sort of briefly share sort of the results from, we just did a survey with over 500 Canadians and American adults who do not have chronic pain. And we're finding similar findings amongst adults without chronic pain, that there is an increase in perceived pain intensity amongst sort of brain-based explanations, and also pity and sympathy, right? So again, very consistent with some of the literature on medicalization and some what we see in disability studies. And then the second question, so the second question again, remind me again, is the
if you have some sense of
why
properties
right.
of
So
these
yeah,
technologies.
so I'm not entirely sure. So I'll give a two-part answer. One, so in some qualitative work we've done where we've asked people, like why, like they really, and I mentioned it briefly here, it's like why would you want, like it's like, oh yeah, I would love to see a picture of my brain. And I think it's because we live in we live in a what I'll call a neuroculture. We describe ourselves often as in terms of our brains. I just got I was on social media and got a dopamine rush from all the likes or something, or adrenaline rush from that run, right? So we have this folk neuroscience or folk psychology that we draw upon. And there's been a lot of others like Nicholas Rose, Joel Avirashid, and others who have written a lot on sort of neuropolitics, neurosociology, and sort of the age of the brain. And so I think there's something unique about the brain and its links to identity, which why people find it so attractive. So again, why that neuroessentialism piece I think comes out in the literature is because the seat of the soul is no longer in our heart. It's our brain, right? We are our brains. And so if you have a diseased brain, that means you are somehow diseased. So I think there's something very intuitively appealing about that. And also in this pain project I mentioned, we're moving now into another phase where we're going to be interviewing people who live with pain, other healthcare professionals about some of these same questions, hoping to get some really thick descriptions and in-depth answers about this very question. you know, what is it that is appealing? We may not get into the machine learning aspect so much, but I think I suspect, and I think this is really a worthwhile area of future empirical work, is so intuitively I have the sense that, and that's why we just sort of did that other study, which is like there's something about machine learning and maybe the hype around it, maybe you know the ability to draw upon all of these, like leveraging these big data sources which are already perceived to be, you know, very objective and real, as being somehow closer to capital T truth than any other sort of subject. So that's my gut, that's my hunch, but I think we'll see. Thanks.
I'll try to keep it brief. Again, a ton of fantastic ideas in there, and really, I want to follow up on the testimonial injustice, which I didn't hear before. I know the epistemic injustice, and I just wanted to give a bit of a remark that might plant the seed maybe to extend this discussion, because like in psychotherapy, we have had this rape psychotherapy debate for years, where clinicians object to the huge investments in like protocols that tell them what to do, which is good in the basis, but then of course you still need clinicians to apply all sources of knowledge, like scientific knowledge, clinical knowledge, intuition, experience, patient information, but also their own experience, etc. You combine that into evidence-based practice. So that sets apart evidence-based treatment from evidence-based practice, and evidence-based practice is way broader than just the protocols that have been developed scientifically. Now, this testimonial injustice is so interesting to me because we talk about testimonial injustice where patients are not taken seriously anymore. But I think that by this whole AI stuff, it is also starting to apply to clinicians themselves. Because basically we don't take the speech and the intuition and the experience of therapists seriously anymore either. Because they're just based on intuition and experience. So whatever, not evidence-based, right? And that's very tricky because all of a sudden, not just the patient, but also the therapist gets surpassed. And therefore also this whole dyad between like this patient therapist dyad, which is so important for the efficacy of a treatment at all, might also get completely surpassed. So that's, as a remark, I think that might be very interesting to also look into and take into account into the bioethics.
Thank you so much for that. I mean, I think, so I'll just first say that sort of testimonial injustice is one dimension of epistemic injustice. It's also called something called hermeneutical injustice, which I didn't get into at all, which is also actually could be quite interesting in looking at this space, and in mental health in particular. But I would say that, so I think I really appreciate that suggestion. I think that's really interesting. I mean, so I ultimately do not think that clinician expertise or content expertise will be sort of thrown out. I do foresee a situation where there is more of a, like AI's, so I'm in the camp that AI will eventually be used as a, or ML will be used as a tool to support decision making, but I do think in terms of thinking along the epistemic hierarchy, clinical content, expertise and knowledge, or professional intuition, or clinical intuition, or practical wisdom that, you know, that we celebrate a lot in healthcare professionals, may not be that high on an epistemic hierarchy compared to the algorithmic opposites on these technologies. And you know, I think that is a real potential. You know, there is some research that is starting to look at how clinicians and others engage with these technologies and their perceptions of it in this way, and you know, whether people see sort of the algorithmic system as expert or as more so expert than the clinical expert. But and obviously at the bottom of this hierarchy you have patient experiential knowledge too, right, which is sort of considered sort of less so. And so more folks are sort of writing on this, but I think that's a really great point.
1 minute and 2 questions. So Anne-Marie, then Joe.
Yeah, very quick.
Brief.
So very interesting, but also a little bit mysterious. So I was wondering if you could say a little bit more about how a client could be epistemically humble, let's say.
Sure. Yeah, thank you for the chance to clarify that. So what I mean by that is that there's sort of like an epistemic trust, or maybe I think probably better characterized as reliance as opposed to trust. I know there's a big debate in the literature about trust versus reliance, and whether you trust the tech anyway. But I think it's more of like a sort of a strong epistemic trust. And maybe this is getting to the question earlier, in that, you know, we place a lot of levels of epistemic trust in medical tests in general, right? From someone who, let's say, draws your blood, and how, you know, they did it accurately, they put the right vial, you know, in the thing, they send it to the right lab, your sample was tested, the right tests were done, and the results come back as producing sort of knowledge. And we trust it, we place a lot of trust in that process. And so I think what I'm sort of maybe flagging here or highlighting here is that, if machine learning or AI or brain imaging, all these the collective outputs are considered to be epistemically superior knowledge, we have to place a lot of trust in the process that came to produce the knowledge. But we know there's a lot of problems with data quality. We know there's a lot of problems with biased algorithms for various biased data sets, how they're trained, and all these problems that people have been writing about. So I think maybe, I don't know if claims is the right way to characterize it, but I think the idea is that we ought to be, or clinicians ought to be reflective and reflexive about how we are using the knowledge that's produced in this way in terms of better patient care, higher quality patient care. So a little bit of humility with respect to that process. If there's a better way to characterize this, I would love to chat about that more and figure out it, but that's sort of the idea that Joe?
Yeah, I just wondered if you could comment on the intersection between, you mentioned a number of times that healthcare professionals have amongst the highest levels of stigma. And how do you talk to me about the intersection between clinical intuition and stigma?
Oh gosh, do you want to? We can go. Maybe later. I think so. There's. Let's chat more in depth later. But quickly, I'll say is that we have a lot of conscious and unconscious biases, which I will separate from the concept of intuition. But I think we should acknowledge that healthcare professionals are human beings like everyone else, and have these biases and harmful attitudes, and particularly in a mental health context. And I'm not sort of putting any sort of blame on any individual healthcare professional. I think this is a product of the society we live in, the worlds we've created, the systems that we operate in, that we've designed, contribute factors such as burnout, empathy fatigue, et cetera, contribute to all of these things and attitudes. And so I absolutely think someone's intuition about a particular patient and what their priorities are, what they value, what they might need, could for sure be influenced by conscious or unconscious biases and attitudes that they have either toward the patient themselves for various reasons. They might be frustrated or what have you, or they're trying with a particular patient and nothing seems to be working. And that might influence how they decide to approach a particular situation. So I think there's absolutely opportunities there. I think any sort of corrective to that has to be structural, has to be in how healthcare professionals are trained, how we understand mental health in society, and also at the sort of more the individual level, that reflexive practice. That's the short answer.
And with that, let's thank Dr. Buchman.